it's always good to hear them again. And I think that for me, doing endoscopic ear surgery was really absorbing information from the same speakers giving the same talks over a period of several years. Because these were all my faculty that would come to St. Louis to work with me and Tony Mikalik, and after that in Boston at the Harvard Medical School of Math Science. So anyway, so thrilled to be here. These are my financial disclosures, of which one of them, 3&2 Medical, does have an association with endoscopic ear surgery, but they do not produce a commercialized technology yet. So that's my list of financial disclosures. So briefly, my rationale I like to talk about for why I decided to convert from a traditional microscopic practice to endoscopic ear surgery. Go over briefly some more setup things and key instrumentation, which I believe we already touched upon, so I probably won't talk much about that. And really talk more about anatomy and basic principles. So to clarify terminology, otoendoscopy is the use of endoscopes to examine the ear. Endoscopic ear surgery, of course, is the use of the rigid endoscope to perform the surgical procedure, and this is obviously the focus of this 2-day course here in Olomouc. And so in terms of terminology, transcanal endoscopic ear surgery, or TEES, is the use of the endoscope through the ear canal to perform middle ear surgery, like we saw earlier today. And this is a terminology that I actually just developed or made up a few months ago. Transmastoid endoscopic ear surgery is the use of the endoscope placed transmastoid in a canal up dissection to remove residual disease that you cannot see through the ear canal. So for me, using this technique has allowed me to reduce the number of canal wall down procedures that I do in my practice, because I can use the mastoid as an alternative surgical corridor, endoscopically assisted, to remove disease without having to fiddle with a microscope and trying to do a lot of dissection to be able to expose the attic transmastoids. Don't forget that the endoscope is a really great tool for looking through the mastoid. So if you have time tomorrow in your dissections in your bones, if you have a canal up dissection, you can then put the endoscope through there and take up disease. So of course we know the reason why most of us switch is that the view is just superior than even the very best binocular microscopic systems. Transcanal cases, I'll tell you, are difficult to do, especially if the ear canal is small or tortuous. And as someone who teaches every day I'm in the OR, it's also much more difficult to teach a transcanal procedure when I'm looking through the side arm of the microscope and my resident's looking through the binocular surgical side. The view you get is never as good as when you're under the surgical microscopic optical head. And so having the endoscope doing heads-up surgery, and everybody in the room gets exactly the same view. Extensive bone removal obviously can potentially be reduced because we can access complex middle ear disease through a transcanal surgical corridor, and of course teaching residents is just vastly improved when using an endoscopic approach. So advantages, you can improve your access visually. However, the instrumentation I think clearly needs to be improved and refined. Avoid using a speculum. A lot of my colleagues in neurootology in the States ask me, so Dan, how do you use the speculum and the endoscope together? I mean, how does it actually work? It doesn't work. It's not meant to be used with the speculum. The idea is that the cartilaginous meatus is a beautiful place to anchor your endoscope and to move it around. And in fact, you can actually stretch the meatus wider to get greater access to improve your vector depending on the angle that you were using. So it's probably hard for you to tell during the cases this morning, but in fact I was using a lot of these angles by really gently pushing the endoscope against the cartilaginous meatus. So when you have your specimens tomorrow, really practice seeing where you can park the endoscope in a stable position to be able to improve your view, looking either up or down, forward or posterior. And of course, by using an endoscope, we reduce the number of times we have to do a traditional post-auricular incision. So this is a patient from my practice with a right-sided conductive hearing loss. And this is taken with my Leica OH4 microscope, and it's a beautiful system, beautiful optics, a pretty good camera system. And this is the best picture I could capture in this transcanal dissection. So this is superior, inferior, anterior, and posterior. This is the sputum that I partially removed. That's our chorda tympani nerve. And so what's the pathology seen on this transcanal right ear? Why does this patient have a conductive hearing loss? The patient has spontaneous erosion of the long process of incus. So you can pretty much make the call even on a microscopic view. But then 2 minutes later, took the speculum and the microscope out of the way, brought in my 0-degree endoscope, and so you get the same information, but in a much more enhanced experience visually in terms of a broad field of view, tremendous depth of field. You can now see the chordae tympani, which you can see here, but then you see the entire pathological situation there, the spontaneous erosion of the long process of incus. We now see the entire stapes, the body of the incus. We now see the cochleoform process, facial nerve, tympanic segment, the entire cochlear promontory, and now we see even the round window niche, the fustus, and your subcochlear canaliculus. So all this can be seen even with a 0 degree endoscopy. So one of my points this morning was you really want to stay with a 0 degree for most of your dissection and only convert to a 30 or 45 if you can't see around a corner. Because a 0 already gives you a tremendous wide field view. Because it's really about basic understanding of anatomy in ways that even experienced otologists thought they knew. So as one example, I was taught that cog was a ridge of bone that separates the anterior from the posterior tympanic space. In fact, that's really not correct. It really separates the anterior attic from the supratubular recess. And because we see this area repeatedly, even without removing any bone, we begin to think more and more about these nuances and relationships. And so a small example of how the endoscope has really redefined anatomy and ear. And so another case from our practice, this is a right-sided transcanal tympanotomy for otosclerosis. So in the surgical position, superior, inferior, anterior, and posterior. So long process of incus. Your tympanic segment of the facial nerve. Stapes superstructure, your incudostapedial joint, your stapedial tendon, the cochleoform process, which gives rise to your tensor tympani tendon, the round window niche, which has a lot of relevance these days when we talk about the future of inner ear regeneration technologies, small molecules, will it diffuse or not if there's a pseudomembrane there. It's been a hot button topic in the fields of regeneration. The round window overhang or tectum or tegmen, the promontory of the cochlea, the sinus tympani, that elusive space that even in a canal wall down scenario you don't always get a chance to see very easily, except with an endoscope. The posterior pillar, a very important area that we like to saucerize if you're doing a cochlear implant procedure. The anterior pillar, the funiculus, which is a ridge of bone that spans the gap between the cochlear promontory and the hypotympanic air cells. And of course, in this case, a patient with classic otosclerotic findings. This patient had stapes fixation exactly like the case we saw this morning. This patient then, we're looking with an angle rather than a 0 degree endoscope, and so we're pointing anterior superior in this right ear. Cochleoform process, tensor tympani tendon, and the cog. Again, this is the bony landmark that was something that we talked about but didn't always really see often when I was in training, and now I see it consistently in the OR every single time. And again, it separates the area between the anterior attic and your supratubular recess. And this is an area important to be able to clear in patients with an extensive attic cholesteatoma. Another patient from our practice, this is a transcanal tympanotomy, also for otosclerosis, and so stapedial tendon, facial nerve, tympanic segment, the undersurface of the malleus, the undersurface of the tympanic membrane, the funiculus, the subcochlear canaliculus, which is an aerosol system that leads you to the petrous apex. So this is an area that potentially could be dissected in somebody with a symptomatic petrous apex cholesterol granuloma. The fustus. Who has heard of the fustus before? Fustus. Any takers besides? Well, of course. So the fustus is a really great landmark for CI surgeons. Why? Because if you dissect this fustus in the lab tomorrow, this bony ridge is in fact coplanar with the floor of the scala tympani. So if you were to drill this all the way forward and enter the cochlea, you'll enter the floor of the scala tympani. And so when those patients with challenging anatomy and you're struggling to identify correctly where to access your cochlea for a cochleostomy, find the fustus and it will take you home. The fustus is a really fantastic landmark for cochlear implant surgeons. It is coplanar with the floor of your scala tympani. You can confirm that tomorrow in your lab dissections. Your subiculum, which forms this inferior ridge that defines a portion of your sinus tympani, and your ponticulus, which is a pretty wimpy one here in this specimen, but it's a bridge of bone between the parietal eminence and the cochlear promontory. course, your sinus tympani. And then looking at the funiculus, trying to focus on the round window anatomy, subcochlear canaliculus, refustus, subiculum, ponticulus, sinus tympani, your posterior pillar, and your anterior pillar. So the subiculum really is in continuity with the posterior pillar of the cochlea. So again, these are really great landmarks to think about. And when you start doing your dissections, or when you're back in your home institutions operating and you're doing a CI surgery, begin to identify the structures, and you'll see that every single time these are really crucial landmarks so that you don't put an electrode into the subcochlear canaliculus. Because last time I checked, that does not give your patient good hearing. So keep it in the round window. So this is a left ear case, anterior using a 45-degree endoscope, as you can see here. So what is this structure here? Any takers? And what is this called? What's the name of the canal though? Semi-canal, very good. And that makes this the eustachian to your right. And this structure here would be part of the cochlea, very good. So again, internal carotid artery, eustachian tube, semi-canal tensor also. Really great anatomy that you can also take advantage of during your dissections tomorrow. Before you rip everything open, use an angled or 45-degree endoscope. Keep the drum intact on malleus and look forward and see how much you can really visualize without ripping your specimens apart. Because of course, if you open everything up, everything is available visually. Try to maximize what you can see and reach with your angled instruments before you tear everything open. And then you can commence with your dissection, removing bone, and practicing your japanoplasty techniques tomorrow. Of course, that's the cochlea there. So transmastoid endoscopy, a topic that I briefly discussed at the beginning of this talk. And so the way I would do this would be as follows. So after I clear the middle ear endoscopically with an endoscope, I then do a canal up mastodectomy. Then you want to place some sort of, in this case, a moist gauze sponge into the mastoid cavity because you need to anchor your endoscope in some way. If you just put the endoscope on the bony ledge of your mastoid, it's going to bounce back and forth, and you won't be able to stabilize your surgical view. So use some sort of moist sponge or towel, drape it into the mastoid, and provides a beautiful bumper against which your endoscope can reside to provide a stable, happy view, and then you can dissect, and I use a curved suction. So this is a left ear canal mastoid. We place the endoscope. We're supporting it with the moist sponge. And in this case, we can then look through the mastoid and into the middle ear. So based upon this view, again, this is a left ear looking down at the middle ear. Why don't you tell me some of the anatomy here? So what is the structure right here? Let's go the opposite direction. What is this right here? The cog. Therefore, what is opposite the cog?
Oh, that's your
Cochleoform process, which means this is the tendon, which means this space is the supra recess, which then makes this the stapes. So stapes, cochleoform, facial nerve, cog. So this is a very different view of the same anatomy. So getting your bones tomorrow, take advantage of your angled endoscopes and see how much you can reach and see looking from above through the mastoid. Transmastoid endoscopic surgery. Don't forget, it's a really valuable part of my practice because we don't get to see only boutique adenocarcinomas. We see the regular ones too that rage and go backwards in the mastoid.
And you didn't do the posterior tympanotomy in this case?
No. So the question is doing a facial recess posterior tympanotomy approach. There's no need for one. That I use a transcanal angled endoscope to look down to see the area. This is for everything else that I cannot see transcanal. So again, just to go over this, the anatomy here, left ear, through the mastoid, looking down into the middle ear, stapes, cochleoform, tensor tympani tendon, and the cog. Okay. So advantages, obviously, about kids. We know clearly that it provides a fantastic view through a small surgical corridor. We know the canal in kids is going to be much smaller than in adults. On average, the newborn EAC is about 4.5 to 6 millimeters in diameter, in contrast to adults where it's 6 to 10 millimeters in diameter. So it's definitely a morphological difference between kids and adults. We know that, it's been quantified, and no question, this may either make endoscopy or surgery more challenging or more favorable in kids. The advantage in kids also is that the ear canals are a little bit shorter. So up to about a couple of years of life, the ear canal is relatively short. So it might be a little bit more narrow, but it is shorter. So even the more tortuous canals are still accessible in pediatric cases. The other difference in kids is that the angle between the tympanic membrane and the ear canal varies from age to age. And so the angle of the eardrum relative to the canal is actually more acute in very young kids than in older kids and adults. And this actually makes it even more difficult to visualize the hidden recesses. So as one example, this is a 1.5-year-old from my practice. Right coronal CT scan, bony windows, and this is the approximate angle between the ear canal and the drum. Very acute. Conversely, a 12-year-old actually has a much more open angle relationship. And so this also makes it potentially more difficult to examine the ear transcanal with the microscope. Okay, so back to the talk on principles. So in reference to pediatric patients, so these are some of the anatomical constraints that you have to think about. And so in training as a resident fellow at Johns Hopkins in Baltimore, we never did anything, especially in pediatric cases, transcanal. There were always post-auricular approaches for perforation, for chronic ear disease, for congenital cholesteatomas, because of this situation. The angle, which is very acute, of the eardrum in relationship to the ear canal really constrains access in line of sight approaches. And so this is why the endoscope is really a powerful tool, especially for pediatric otologic procedures. And of course, from the patient-family perspective, kids don't like big mastoid dressings. They want to avoid a large skin incision, especially the parents. If possible, they like to get their ears wet, and they don't like to get their ears clean, especially mastoid bowls. And so I know of a few kids in my practice who had huge cholesteatomas that I operate on with the canal wall down, mastectomy, unfortunately, given the extent of disease, where today with an endoscope I can easily have saved that minimum. So it's there's no question that this is really helpful, especially in our pediatric patients. So another advantage that people don't talk a lot about, but I've been talking a lot about, is ergonomics. And so I think we as a profession have failed to think about ourselves and our health when it comes to how we position ourselves and what the long-term complications are from doing 35 years of microscopic surgery. If you've been to any otologic conference where our silver-haired colleagues are hobbling around frozen in the position that they've been in the OR 2 or 3 days a week for 35 years, you know what the problems are. There was a Dutch surgeon in my OR who was in her 30s, and she said that she had to take over her senior colleague's practice in the Netherlands because her 50-year-old colleague, she could no longer do the microscopic surgery anymore because she had cervical disc issues. It stopped her surgical practice in her 50s. And I think women especially might be at greater risk because you have to fight the stack height of your microscope and operate like this. And so it immediately puts additional strain on your upper neck and your shoulders that maybe a taller male with longer arms wouldn't have to battle with. So I wonder the prevalence might be even higher in individuals of shorter stature and women especially. And so these are things we have to think about and really care about. And so just to summarize, some of these slides come from my colleagues Ilka Naumann and Noah Siegel, who talked about ergonomics at the American Academy meeting. Surgeons work on average about 2,500 hours per year. These are ENT surgeons. And about a third of these hours are spent in the operating room. And there's a negative impact on all that time in the OR on our musculoskeletal system. And over half really have responded. Who responded report pain and discomfort due to cervical position. So that's a pretty high number of surgeons who complain about neck or back issues. We all know those long chronic care cases at the end of the day, they're pretty white, especially with those microscopic cases. So this is from the Lancet paper from 2016 by Epstein and Privatera. And I quote them, they say, when burnout was seen as a crisis of well-being affecting physicians' personal lives and work satisfaction, guess what? Nobody cared about that. No one cares about the crying, whining physician. Oh, too bad, you're feeling uncomfortable about your surgical orientation and your position and your body health. Who cares about that, right? But when we now have evidence that shows that burnout actually negatively affects physician effectiveness and patient safety, well, guess what? People now care about this topic, and you need to care about this as well. Healthcare organizations and the public are now justifiably worried. So these really go hand in hand. So burnout has been associated with medical errors as well as poor outcomes. when physicians are struggling with their own physical health. And strain can lead to job dissatisfaction and burnout. Injuries could lead to, of course, medical leave and lost revenue. These are really important factors that I don't think we really talk about generally as a profession, especially in training. Never once did someone mention to me, hey, by the way, this is important for your long-term health. You've got to sit a certain way. And so, our perioperative environments have been extensively studied. Why? To reduce patient injury. No one ever talks about surgeon injury. Maybe using glasses during lasers. That's about it. And this is really poorly understood from a surgeon safety standpoint. So we as a profession, as a specialty, we need to start to collect these data and think about how this is negatively impacting our practices. So Matthew Young in the UK published a really nice paper that showed that the highest prevalence of chronic neck and back issues amongst ENT surgeons are otologists, because we are microscopic surgeons from beginning to end of our careers. So ergonomics, as many of you know, is a study of people at work, and it's based on anatomy, physiology, psychology, as well as engineering. And so this is a great example of appropriate ergonomics, heads up work, heads up dissection, heads up surgery. So the goal of ergonomics is to reduce human error, increase productivity, and of course enhance safety and comfort. So this is one of my former research fellows who's now back in Zurich, Switzerland, phenomenally talented individual. He's training in otolaryngology and in neurosurgery. He actually has chronic neck issues. And so I walked into the lab one day, I said, Lawrence, why do you have your laptop on the box? This looks kind of funny to me. And he said, well, Dr. Lee, if I don't configure myself this way, I can't work. When I get tingling in my feet and my fingertips, I need to position myself so that I'm appropriate and comfortable. And this is what we need to think about when doing any sort of surgery, whatever type of surgery you end up doing. Ergonomics is important, because those who are most vulnerable will feel it right away if ergonomics are poor. Because hunching over, or rather sitting up straight, is obviously very good for your neck and your back, but hunching over is really poor in long term for your back and your neck and your shoulders. And so in this position, he can tolerate this for maybe 30 seconds, and then it's over. So he's going to really be struggling back in Zurich because they use primarily microscopic techniques. So I encourage him to work with his attendings to think about doing some of the procedures heads up. So hunching over is bad for you. So this is my recent fellow who graduated, Nicholas Dewey, and so we're doing a cochlear implant in the right ear, and so we optimize the ergonomics for the microscope. But again, this stack height provides a distance between you and your hands, which can put a strain even on Nick's back and shoulder, who's a taller than average guy. So although we optimize the ergonomics, it's still pretty crappy compared to what we could do and offer with other types of approaches. So this is actually pretty poor posture. So if you had someone come in and analyze ergonomics, they would say this is pretty poor. And this is the best we can offer using a traditional microscopic approach. So these angles are very unfavorable for long-term health. So whereas this is one of my graduates' residencies in private practice, and he sent me a picture of his first transcanal procedure in his private practice. And look at this, he's beautifully sitting in a chair, sitting upright with a screen in front of him. This, I believe, is healthier, more appropriate ergonomics. So endoscopes obviously pave the way for improved ergonomics. And so if you can't make the medical justification to your hospital that you need to try new techniques, I think you need to use this argument. This is a very important thing. Ergonomics are important. We should care about this, and we should make sure that we quantify these data to understand what the impact is, economically, to how we provide care for our patients. So, very good ergonomics here. So this is a patient who came to me with a chronic ear. So this is a right ear of a really nice woman in the cervical position. So the patient is supine. What's the diagnosis of this patient?
She's from Missouri.
She's not from Missouri. But possibly. Do you know what condition might cause her to have a neck like this? No. But she has like a negative neck. I mean, her neck is like basically non-existent. She has Klippel-Feil syndrome. So recall that these patients have congenital cervical fusion. So this is an absolute ergonomic nightmare for a microscopic surgeon. How can we do this transcanal? You're a right-handed surgeon. The shoulder, there's nothing, you can't increase the angle here. But with the endoscopes, it's really not a problem at all. And so anatomic limitations can really be overcome either with endoscopic ear surgery or my favorite new topic, exoscopic ear surgery. And so this is really encompassing a field that I like to call heads-up surgery, heads-up ear surgery. Endoscopes for small surgical corridors, transcanal middle ear surgery, or a transmastoid endoscopic assisted dissection. And exoscopes for open surgical corridors, cochlear implant surgery, canal wall down mastectomies, craniotomies. Exoscopes stand for extracorporeal scopes. So these are digital microscopes that I think will replace all traditional optical binocular microscopes in the future. Digital microscopes. I would recommend paying attention to this field because eventually it will replace every single microscope out there. I truly believe that. So this is an example of an exoscope. This is, again, my former fellow Nick Dewey. We're doing a transmastoid dissection for cochlear implantation. So this is one company that makes an exoscope. So basically, the exoscope holds a 3D camera. You wear 3D glasses, and you watch the surgery off the 3D video system. And so you're able to operate very comfortably, heads-up surgery, to do a mastoid dissection. So again, this is to replace a microscopic dissection, not to replace an endoscope. Rather, these are two complementary approaches that we think can then take care of your entire surgical needs as an otologist, or a laryngologist, for that matter. Think about laryngologists who have to fight the stachyte and reach through the laryngoscope to do their procedures. It can be a real struggle. And for short-arm residents or even attendings, this can be really difficult. This reduces the stachyte by half. You can comfortably sit there, vocal cords are this tall, and you can complete a surgery very safely that way. So, endoscopes and exoscopes, I believe, are really great for heads-up surgery and enhanced ergonomics. So surgeon safety, I believe, equals patient safety. So I think we need to care more about this. It's okay to think about yourself. It's okay to think, hey, listen, it's important that I need to be safe as a surgeon in order to provide the best possible care to my patients. And there's an economic price to pay if we don't do this in the long term. So again, to conclude with this basic talk on principles, no question we can get better views of the hidden recesses. Transcanal dissection is possible. I do 100% of my middle ear work transcanal endoscopically, except for maybe large glomus tumors where I need more controlled bleeding. I need second hand. Reduced need for canal up or canal wall down mastectomy, and so I rarely do a canal down mastoid for primary disease because I oftentimes do a transmastoid endoscopic dissection of disease. And I didn't talk much about outcomes, but the current published data suggests that the outcomes are fairly similar in terms of rate of residual and recurrent disease. I wanted just to thank everyone who came, especially Professor Saltzman for supporting the Congress in 2019. In June, we had a number of delegates, over 450 from 50 countries, so thank you all for coming. I really enjoyed that Congress. Tony, we missed you, man. So, all right. And see you in Kyoto in 2021. And my last slide, actually, please take a picture if you want. The website for the Congress is updated now, so you can actually access all the videos from the two main rooms of the Congress that occurred over 3 days in Boston. So this is the link, and then you can, this is the password to be able to access the videos. And I believe a couple of videos or sessions were featuring Professor Saltzman, so I think he charges €5 every time you click a download, so yeah. Anyways, questions about basic principles or ergonomics. Like, no one ever talks about ergonomics, but I think it's extremely, so important, very important. And the folks in the UK, Matthew Young, who has a sports medicine background, as I learned when I was in Japan with him last month, is a phenomenal speaker on this topic. I told him he should be circumnavigating talking about ergonomics, because that's his left. He's got a PhD student who's focused on ergonomics for otology.
Actually, as you just spoke, I just thought maybe it would be a good PhD topic for a physiotherapy
No
person.
question. It's an ongoing point of discussion. Mm-hmm. Matthew Young actually invented a surgical chair. Have you seen this chair? It's called the postural support chair.